So our next speaker, I'm thrilled as usual to introduce Dr. Sue Koh. Sue is a radiation oncologist at Liverpool Hospital. She's very well known in the neuro-oncology community. She currently chairs the COSA Neuro-Oncology Group, which is our national neuro-oncology group. COSA is the Clinical Oncological Society of Australia. She's also the deputy chair of COGNO and the deputy chair of COGNO's Scientific Advisory Committee as well. So she's very busy. In addition to her interest in neuro-oncology, she's also a leading figure in the survivorship arena as well. So she's a wonderful researcher, a leader, and most importantly of all, she's a compassionate clinician. Please make Dr. Sue Koh welcome.
Thank you very much, Liz, and it's a pleasure to be here. And it's actually, honestly, one of my favourite forums of the year, and it's always a wonderful reminder and a humble reminder of interacting with our patients and carers, and the beauty of being able to meet different families across the state that you don't look after directly. So it's a great pleasure to be here. So my charge the next 15-20 minutes is to speak about some evolving principles of radiation, and I think it follows very nicely after Jonathan's talk and picks up some very similar themes in terms of our treatment evolution and techniques over time. I'm going to focus mainly on glioma, but also highlight some situations and scenarios where, of course, we use radiation for patients with benign tumours such as meningioma and pituitary tumours. So essentially I'm going to cover a few areas, and I'm going to start to talk about some of the mechanisms. How does radiation work? So one of the common questions we're asked, what are some of the benefits of radiation when we treat patients with glioma? Some of the advanced technologies, and I'm going to show you a few cases, examples where we've seen tremendous advance in technology as it relates to brain radiation and radiation overall. Talk about some side effects of radiation, and some of you will know this very much from a personal experience as well. And finally, talk about some of the future evolving directions in radiation. So one of the common questions I'm asked by patients and carers is, how does radiation work? And I guess what I start by saying is that it's similar to having a chest X-ray in that delivering radiation and receiving it is invisible, it's painless, you don't see or smell anything, it's quite quick to deliver the radiation over a period of minutes. But the main difference in giving treatment or therapeutic radiation is that the energy we use for therapeutic radiation is much more powerful and penetrating, and it's much more targeted, designed to actually deliver a specific dose to a certain target. The machines we use are called linear accelerators, or LINACs for short, and you'll find them in every cancer centre in a Western setting and in other settings as well. And the main mechanism by which radiation works is it actually affects the DNA at a sort of cellular, subcellular level. And the other question I get asked is, well, doesn't radiation affect the normal tissues? And that's a very insightful question. And the simple answer to that question is that it does. However, normal tissues have the ability to repair over a period of time, because normal tissues generally have intact repair mechanisms, whereas tumours and cancers generally don't. And so as the radiation is given over a course, or what we call fraction by fraction, over a block of time, usually a block of 5 or 6 weeks for glioma patients, we see that normal tissues heal and repair, but the tumour tissues don't. And so we've known that radiation has had a very significant role in brain tumour care for many, many decades, and this is an old graph, and I have showed this previously, but just to say that this is not a new treatment, but clearly it has evolved very substantially in the last number of decades, and I think that evolution of technology will exponentially grow over time. And essentially showing, this is from data many, many decades ago, that over and above best supportive care, and by that we mean using medications, particularly dexamethasone or steroid medication, that radiation conferred prolonging of life over and above best supportive care and over and above chemotherapy, and also an early hint that patients who are managed with both chemotherapy and radiation actually have the best outcome. And fast forward to this very seminal and practice-changing trial which was led by Roger Stubb, a Swiss oncologist. And a lot of us in the room will be familiar with this trial, and I'm sure Hao-Wen will refer to it. But essentially, this was a randomised trial of almost 600 patients where they gave radiation as the backbone, and the radiation was given for 6 weeks. 30 daily treatments over 6 weeks, and they compared this to radiation, 60 Gray, Gray being the unit of radiation, plus an oral chemotherapy drug called temozolomide or TMZ. And we know that the patients receiving both chemotherapy and radiation had an improved survival compared to those that received radiation alone, and that this benefit was sustained over time. So I just wanted to flag, and I think as Jonathan has spoken about with relation to surgery, radiation is also a local treatment, meaning we can target very precisely specific parts or anatomy of the body and spare other adjacent normal tissue. And to do this, we use several different measures. The first thing is what we call a safety shell or an immobilisation mask. And although it's quite confronting to perhaps have this made, it's very important that the patient is stable and not moving, because even sub-millimetres of movement will affect the accuracy and the delivery of the radiation. So at the time of radiation measurements, where we require CT scan, patients who have brain and also head and neck treatment will have this safety shell made. You can see it's like a netting, so people can breathe through it, but it holds them quite firmly in place for the few minutes that the radiation is being delivered. Again, in every radiation department, you will find what we call a CT simulator. So simulation, i.e. It simulates or plans or maps out where the treatment will be, and essentially is very similar to a diagnostic CT scanner, but has some specifications that we use for radiation planning. And you also find that in a growing number of centres across Australia and internationally, we also have an MRI simulator, which by the same principle is an MRI scanner, but tailored towards radiation planning. So the point is that we can use maximum scan information, be it CT scanning, MRI scanning, and other scans, to help us plan and deliver the radiation as accurately as possible. So I want to give an example here of a radiation plan, or what we call a dose map. So it's similar, I guess, to when you look at a weather map, where the similar colours represent areas of similar dose, with the area in red reflecting the area of highest dose, and the green a lower dose around it, and you see the yellow wash around that. And the important, I think, to note is that we can target the radiation exactly to where, if there's any residual tumour, as Jonathan was talking about, the principle of gross total resection, even if the surgeon has removed all visible tumour, as Jonathan showed from his slides, there we know that in glioma, particularly glioblastoma, there is microscopic invisible tumour around the visible tumour on the imaging, and therefore the radiation, not being as limited as surgery by the anatomy, is able to sculpt dose in a quite sophisticated manner, so that we treat any microscopic disease, any visible disease, and spare important structures such as the brainstem that you see there in orange, the eyes, the optic nerves, and the lens of the eyes, for example. This slide actually is of an adolescent male who's 17, treated for a low-grade brain tumour called an astrocytoma. And the point of showing you this diagram is that, again, it shows you quite a sophisticated radiation dose map of what the plan looks like. So it's not a question of just giving dose, but it's a very sculpted, very targeted, very well delineated and thought out plan. But we see that there are, in addition, particular leaves here, which we call MLC leaves. And basically we can shield and sculpt the dose very precisely to millimetres or even sub-millimetre accuracy, so that we really sculpt and treat the tumour or the target volume and spare the normal tissue. And then further to that, it's not just the plan that's a very sophisticated plan, and that may take some degree of weeks to actually create, develop, and QA and check. But the more important aspect also is that during treatment delivery, we actually have the technical ability to verify or ensure that the treatment that we had planned is the same as what is actually being delivered. And the means by which we do that are various technical devices, and one of which is called a cone beam CT, which is essentially a low-dose CT that is attached to the Lin Accelerator machine. And as the treatment is being delivered, we can actually acquire these low-dose CT images to tell us that, or to verify that the treatment is as is delivered as being planned, as was planned. And so this is an example actually of a child who had radiation before, had a recurrent tumour, an anaplastic ependymoma, which is a rare brain tumour, in a very tricky location, right next to the spinal cord. And this was the second course of radiation, but you can see how tight the radiation volume is sculpted adjacent to the brainstem there. So the point is that we really have the technical ability to treat very precise targets accurately and safely. Moving to a case of meningioma, this is a benign brain tumour. You can see this brain tumour here located close to the optic nerves and the optic apparatus, particularly on the right, and an area where the surgeon was not able to safely remove the tumour without certain risk. And so radiation can be used at a lower dose. We normally treat compared to glioma patients. Again, protecting the brainstem, protecting the optic chiasm and the optic nerves on the right and the left, and being able to really accurately delineate that with MRI and CT. I want to move now to some other factors and ask some practical questions about radiation. One of the questions we are asked is, well, what is the optimal time to start radiation, particularly in the setting of a patient with high-grade glioma, or grade 3 or grade 4 glioblastoma? So this is an old paper actually from Westmead Hospital by some colleagues of mine who actually wanted to answer this question with some evidence. And the question was, well, from the date of surgery to the date of referral, how quickly should a patient start radiation treatment, bearing in mind that their wound is healed and there are no problems with infection, for example, and they're fit to start treatment. So they looked at just under 200 patients, and they looked at the wait times, either from biopsy or surgery to the start of radiation, or from the time of consultation to the start. And the important take-home messages from this study, although it was a relatively small but important Australian study that really sort of influenced decision-making at that time, was that patients who were older, patients who are less fit, ECOG essentially stands for performance status or fitness, patients who had a lower dose of radiation, and importantly, patients who are waiting a long time from surgery, consultation, and then to starting actually did less well over time. And for that reason, this kind of evidence really shaped our management across different centres in Sydney and across Australia at the time when there was quite a blowout in wait time to start radiation, really substantiating the fact that patients with high-grade glioma should start radiation as soon as it's practically possible after they've recovered from surgery. So what then are some of the side effects of brain radiation? I think no treatment is without side effects or potential risk. Some of the common side effects I've listed here, those in the short term, so while people are going through their course of radiation treatment, would be fatigue. There's no doubt that patients, no matter what age, young or older, do experience a varying degree of tiredness or fatigue generally. Because radiation is a targeted treatment, all the other effects then pertain or relate to the area of treatment. So with regards to brain radiation, there is some patchy hair loss in the treated area. It's not a global loss from all of their scalp, but where the beam actually enters and where it exits, we can see hair loss, usually about week 3 or week 4, so halfway through their radiation treatment. It can regrow, but I tell my patients normally it can take some months to regrow depending. There is a mild to moderate redness of the skin, but that usually settles down completely after treatment. Some patients can experience pressure symptoms like headache or feeling a bit nauseated, but that can be anticipated well in advance with appropriate medication given. In the medium term or subacutely, some weeks to months after treatment is completed, the main ongoing symptom is that of tiredness, or what we can call somnolence, where patients feel sleepy and have to have more naps and rest over time, and generally that settles down with time. We do see it a little bit more in patients who are older or less fit, but to a varying degree people can experience that. And finally, with respect to some of the longer term side effects of radiation, it's difficult to pick out because often patients are on medications such as steroids, but there can be some longer-term effects on hormone function, depending if the tumour and the treatment area was near the pituitary gland, which is a hormone gland in the front and centre of the brain, responsible for very important hormone endocrine functions, and some effects on what we call cognitive function as well. I just want to focus a little bit on cognition because this is obviously a very relevant and important topic for our patients and carers. And I just want to show you just one study, but there are a number of studies that demonstrate the same point. This is a study now published 10 years ago by a European group looking at 65 patients with low-grade glioma, so grade 2 glioma, who had survived a long time after treatment. And in fact, at the time this study was done, the median follow-up of this group of patients was 12 years, ranging from 6 to 28 years after radiation. And I think what they did do was they performed quite sophisticated neuropsychological testing at 2 time points, and they showed that on long-term follow-up that we did see patients who had undergone radiation treatment for low-grade glioma did demonstrate changes in their cognitive function over time. And I think that could be attributed to, in part, by the radiation. So I guess a few comments I'd like to make about these sorts of studies are that, one, I do accept as a radiation specialist that radiation can cause cognitive changes, and we therefore need to make very important decisions about the timing and the patients we choose for radiation, especially those that we project will live many, many years to come and may experience these long-term effects. We do know that the effects of ageing, we know the effects of medication, post-surgical changes may contribute to this, and so it's hard to pick out and say it's due to the radiation or due to the medication or due to ageing effects. My sense is that it's due to all of these factors enmeshed together. And the final thing to say is that with advancing technology, the radiation that these patients had in the 1990s or the 2000s is quite substantially different in terms of a large volume that they received as a much tighter volume, a smaller volume of brain that was treated. We can shield and protect structures much more than we could do back then. And the dose is different, and the dose per treatment is also different. So I think with all those benefits, hopefully we will see less long-term effects in relation to cognition over time with our current patients. I'd like to flag one newer issue that's come up over the last 5 to 7 years internationally, and that is the increasing acknowledgement of the role of the hippocampus in cognitive function. The hippocampus is actually a structure located on both sides of the brain, a right and left side, in the temporal lobe. And there's been increasing acknowledgement that this part of the brain is particularly, in part, responsible for short-term and longer-term memories. And we know that in Alzheimer's disease, a type of dementia, the hippocampus appears to be one of the first regions of the brain to show changes or damage over time. And so the question then arises, when we're giving radiation to the brain, should we be actually thinking about avoiding the hippocampus so as to reduce the risk of radiation-induced cognitive changes over time? And we know that, as I mentioned, the hippocampus has an important role in memory and recall, spatial processing, for example. And the question is, technically, do we have the ability to sort of shield the hippocampus without, of course, shielding the tumour or the target volume? And the answer to that is, fortunately, yes. And so where hippocampal avoidance radiation has been used, it's mainly been in the setting of whole brain radiation, where very large international trials have proven that we can sculpt dose to protect the hippocampus but not shield the tumours, because the tumours tend to sit away from the hippocampus. And this just is, again, a radiation map showing that very nicely the radiation dose can sculpt around it using these particular techniques. A few final slides in closing. Another common question I'm asked is, well, if I have radiation treatment to my brain now, can I have it again in the future? And I guess the answer is conditional, maybe. It depends very much on the individual patient and their circumstances. It depends on the fitness. It depends on the time interval between the first course and the second course of radiation. It depends on the location of the tumour, where it was at the first time and where it may be in the recurrent or the second setting. So there are a whole lot of variables. And the thing is that even though there is some repair and healing of radiation over time, in effect, the body always remembers that radiation received to that part of the anatomy forever. So although there is some healing, it makes second course radiation somewhat challenging to give the second time. As Jonathan was talking about, we have stereotactic radiotherapy, which is essentially being able to deliver very precise radiation in three dimensions with very precise localization. Some of you may have heard about the Gamma Knife, which there are units in Macquarie here in New South Wales and also in Brisbane, Queensland, where Gamma Knife technology is a very specific type of radiation technology used for very specific situations, particularly for patients with secondary brain cancer or metastasis, less so patients with glioma. And my couple of closing slides in terms of upcoming frontiers and future directions is that I think Jonathan mentioned about using PET scans. And some of you may know that the traditional or most common PET scan or PET tracer is called FDG. But we know that FDG, when it's injected, does not actually help us very much in the diagnosis and management of our brain tumour patients, because the brain is such an active organ and it actually uses that tracer very actively normally. So you can't actually see the differentiation of normal brain from the tumour. But there are some newer tracers, and one of them is called FET-PET, or fluoroethyl L-tyrosine, which actually may be more sensitive to detect brain tumours compared to the standard FDG. And we actually are embarking on a national study this year and next year, rolling out across 10 hospitals across Australia to actually ask the question, what is the role of FET-PET together with MRI in patients with glioblastoma, both in diagnosing and helping delineate radiation target volumes, as well as diagnosing tumour recurrence. So that will be an interesting and quite a landmark trial, we hope, in the coming years. And so to summarise, I think the benefits of radiation, hopefully I've been able to relay that there is a very substantial benefit of conformal targeted brain radiation, particularly in the setting of patients with glioma, high-grade glioma, but also in patients with low-grade glioma and benign brain tumours. I've hopefully been able to address some of the common questions in relation to side effects, that the timing of radiation is important post-operatively, particularly for patients with grade 3 and grade 4 glioblastoma. Repeat radiation is possible, but it depends on a range of factors. And very much similar to surgery, there's very much an advance in technology to help us target the tumour, but also spare very important normal structures, particularly those responsible for cognition. And so with that, I will hand over to Hao-En and for his talk about systemic therapy, which I hope will synergise well with the talk so far. Thank you very much.